Complex case study covering cerebrovascular accidents, diverticulosis, and hypertension, presented by Andrea Puricelli. The case study patient is a 68-year-old white male who is 5 feet 5 inches in height and weighs 167 pounds. He has a past medical history of dementia, transient ischemic attacks, diverticulosis, and hypertension. He has no major illnesses within his family history. The patient is of the middle socioeconomic class, and he is a hardwood flooring installation company business owner. He is divorced but lives with a new fiancé, and his highest level of education is a high school diploma. The patient does not smoke or drink, and prior to this admission, the patient was experiencing altered mental status. The patient was admitted to an acute care facility to undergo a CT scan after presenting to the emergency department with an altered mental status and in a dysphagic state. 11 days later, the patient was admitted to a long-term care facility to undergo speech, occupational, and physical therapy, as well as monitoring his diet progression. Cerebrovascular accident. A cerebrovascular accident can be defined as damage to the brain due to an interruption of its blood supply. Its pathophysiology consists of two main mechanisms which initiate stroke-related brain damage, and these are hemorrhage and ischemia. The first mechanism, a hemorrhagic cerebrovascular accident, is often immediately fatal. During this type of stroke, a rapid accumulation of blood within the brain precedes the rupture of a brain blood vessel. Certain sites within the brain, such as the thalamus, cerebellum, and brainstem, are often the location for such cerebrovascular accidents. These sites, along with the surrounding brain tissue, will be damaged by the pressure produced by the swelling of the aggregated platelets. This increase in pressure may result in irreversible disruption of various brain functions along with massive brain cell death. The second mechanism, ischemic cerebrovascular accidents, are complex and may be associated with variable clinical manifestations and etiologies. When such a stroke occurs, brain cells are deprived of both glucose and oxygen due to an interruption in the blood flow to the brain. This deprivation is critical because normal brain functions may be altered or prevented completely. Obstruction of the blood supply to the brain may occur as an artery thrombus or an embolism of an artery. A thrombus, also known as a blood clot, may form in either the arteries of the extracranial or the intracranial region when the walls of the artery are roughened and plaque formation occurs. When the inner arterial walls are roughened, platelets begin to aggregate in the damaged area, which coagulate and ultimately form the thrombus. Since the thrombus forms in the same region as plaque formation, a narrowed artery is further constricted by the blood clot. As a result, perfusion of blood to the brain cells is compromised, and once perfusion is decreased, death of brain cells succeeds. During the embolism of an artery, a cholesterol clot travels from one area and lodges in a cerebral blood vessel. This occurs when a small aggregation of platelets dislodges from a hardened, plaque-filled artery and travels through the bloodstream to another location. During this travel, this clot will lodge in a cerebral artery, preventing blood flow to the brain, which results in the death of brain cells. Symptoms and clinical manifestations of cerebrovascular accidents are dependent on the form of stroke which has occurred. For instance, symptoms such as a sudden and severe headache may suggest a hemorrhagic stroke, while impaired consciousness accompanied by headache, nausea, and vomiting may suggest either an intense ischemic stroke or an early hemorrhagic stroke. Often, general symptoms include muscular difficulties, such as difficulty walking, paralysis, problems with coordination, stiff muscles, and overactive reflexes. Visual problems include blurred vision, double vision, sudden visual loss, or temporary loss of vision in one eye. Whole body issues include balance disorder, fatigue or lightheadedness. Speech may be difficult, slurred, or lost. Sensory may include pins and needles or reduced sensation of touch. Muscle weakness or numbness in the face, and weakness or numbness of the limbs, in addition to difficulty swallowing, headache, inability to understand, mental confusion, numbness, or rapid involuntary eye movement. Several variable risk factors for cerebrovascular accidents exist and include both modifiable and unmodifiable factors. Modifiable factors include smoking, body mass index, physical activity level, dietary pattern, total cholesterol level, blood pressure level, and fasting blood glucose level. Of all the modifiable factors, smoking and poor dietary patterns significantly impact the risk for stroke. However, unresolved hypertension is considered the overall largest contributor due to the damaging long-term force of blood against the walls of the arteries. The risk factors, which are unmodifiable, include age, gender, and race. The risk for stroke significantly increases with age. Therefore, age has the strongest association with cerebrovascular accident risk. In addition, the male gender tends to experience strokes more often than women, while the African American and Hispanic races are at a higher risk for stroke compared to any other race. Of all the variables, the major risk factors for stroke are age greater than 75 years and a previous cerebrovascular accident or transient ischemic attack. Moreover, each of the other identified risk factors are considered clinically relevant for determining stroke risk, but they are viewed as non-major factors. Prevention focuses on avoiding smoking, participating in daily physical activity, maintaining a healthy BMI, avoiding daily consumption of alcohol greater than 5 to 15 grams for women and 5 to 30 grams for men, and consuming a varied and healthy diet. Tissue plasminogen activator, also known as TPA, is a protein produced by the body and is often involved in the breakdown of clots. This protein has been engineered into a thrombolytic drug, which is administered to patients after ischemic strokes. Patients who receive TPA within 4.5 hours of a stroke have minimal to no disability 3 months after being treated for stroke and may require little to no rehabilitation. Aspirin is administered within 48 hours of an occurrence and will significantly reduce the risk of recurrent ischemic strokes. Rehabilitation focuses on preventing recurrent strokes. If comprehensive rehabilitation is necessary, it should be aimed to prevent various complications, to minimize impairments, and to maximize available function. Nutritional treatment for stroke begins with the diagnosis, which should be focused on inadequate energy intake, inadequate oral intake, inadequate protein energy intake, inadequate fluid intake, and swallowing and feeding difficulty. Each of these diagnoses are related to the impairment of the ability to feed, chew, or swallow, which commonly occurs after a stroke. Since the overall nutritional intake is at risk, nutrition support is often considered if an oral diet is unable to meet the patient's nutritional needs. Early enteral nutrition support demonstrates reduced mortality in a dysphagic stroke patients, along with complication prevention and reduced hospital stay. However, As rehabilitation progresses, nutritional care plans must also progress. Furthermore, if a stroke patient is able to chew and swallow, the nutritional management will focus on controlling blood pressure and blood cholesterol levels for the prevention of recurrent strokes. Overall, general guidelines include limiting sodium intake to less than 300 milligrams of sodium per serving, limiting cholesterol to 200 milligrams per day, consuming 20 to 30 grams of fiber per day, consuming less than 35% of fat from calories each day, consuming a variety of fresh fruits and vegetables, choosing fat-free or low-fat dairy options, and choosing unsaturated fats over saturated fats. Diverticulosis. Diverticulosis can be defined as the abnormal presence of diverticula, such as outpockets, sacs, or pouches on the surface of the colon or intestine. Its pathophysiology is not well elucidated. However, it is thought to be associated with increased intraluminal pressure. Since the cause of diverticulosis has yet to be clarified, the mechanism of its pathophysiology relies on theories. This mechanism may be associated with complex interactions between diet, structure, colonic bacteria, genetic factors, colonic motility, and inflammation. The intraluminal pressure occurs when the muscular bands of the colon contract simultaneously in an attempt to propel fecal material through the bowel. These circular muscles encase the fecal material entirely and contract until the material is pushed distally towards the rectum. Instead, this pressure hinders the motility of the colon and the ability to move fecal matter. As a result, feces become obstructive and exert pressure against the walls of the colon. Thus, herniations of the colonic wall occur, resulting in the development of diverticula. Approximately 70% of diverticulosis patients are asymptomatic. Roughly 15 to 25% of patients develop inflammation of the diverticula, and another 10 to 15% of individuals experience painless bleeding. General symptoms, however, may include fever, abdominal pain, gastrointestinal bleeding, and an elevated white blood cell count. Past research suggested that development of diverticulosis may be related to low-fiber diets, recurrent constipation, and long-term colonic pressure. However, recent research suggests that diverticula form due to colonic inflammation, visceral hypersensitivity, microbe changes, and abnormal motility. Such factors may be affected by increasing age, genetics, obesity, lack of physical activity, steroid usage, increased alcohol consumption, caffeine consumption, and smoking. Some experts associate abnormal contractions and spasms with elevated erratic pressure within the colon. This is thought to cause diverticula formation near weakened areas of the intestinal walls. Yet, even though recent research has suggested theories of factors which may be associated with diverticulosis, the exact effect on these factors on the colon and the intestinal walls remains unknown. Several forms of treatment are available for diverticulosis. First, antibiotics are used to treat potential infection that may occur within the diverticula or colonic walls. Such regimens involve antibiotics for infections of gram-negative rats and anaerobes, both of which can be treated with medications known as ciprofloxacin and metronidazole. Generally, diverticulosis is thought to be affected by bacterial overgrowth. This overgrowth is associated with diverticular inflammation, increased exposure to pathogens, and a lack of bacterial motility. Probiotics, or living microorganisms, are often prescribed to inhibit these complications by providing the intestinal tract and colon with healthy bacteria. These healthy microorganisms increase immune system activity by preventing inflammation and inhibiting pathogen metabolism. Controlling bacterial overgrowth and colonic inflammation through probiotic treatment has shown to significantly reduce or control diverticular complications in individuals with diverticulosis. While surgery is not a common treatment for diverticulosis, it is often considered when complications progress to include unresolved inflammation of the diverticula. Procedures such as segmental resection or subtotal colectomy are indicated in individuals where large diverticula cause recurrent abdominal pain or when diverticular bleeding fails to cease. In addition, diet modifications such as a high-fiber diet may also be prescribed. However, if a patient's complications are severe enough to negatively affect their dietary intake, it is appropriate to restrict all dietary intake to allow the bowel to rest. Once complications reside, a gradual return to a regular high-fiber diet should follow. The high-fiber diet promotes soft, bulky stools which move easily through the colon. Since high-fiber intakes require less strain and less pressure to move fecal material through the colon, patients often experience fewer diverticular complications and faster relief from such complications. Dietary fiber should be gradually increased due to the potential complication of gas and bloating with increased fiber intakes. However, these complications will diminish with consistent intakes after 2 to 3 weeks. The recommended dietary fiber intake for women is 38 grams per day, while for men, the recommendation is 25 grams per day. If diverticular patients are unable to consume this amount of fiber from foods, he or she may supplement this intake from fiber supplements. Hypertension. Hypertension can be defined as the persistent, elevated level of force exerted on the arterial walls by the blood. Since blood pressure equals cardiac output, or CO, times by total peripheral vascular resistance, or TPR, the mechanisms of elevated blood pressure must involve increased CO, increased TPR, or both. The diameter of the blood vessel affects blood flow. When the diameter is decreased, resistance and blood pressure increase. Conversely, when the diameter is increased, resistance decreases and blood pressure is lowered. In most patients, CO is normal or slightly increased and TPR is increased. In other patients, CO is increased and TPR is inappropriately normal for the level of CO. The amount of blood pumped per minute, or the cardiac output, may be increased, and the resistance to blood flow may be increased because blood vessels are constricted. Blood volume may be increased also. The reasons for such changes are not fully understood, but appear to involve an inherited abnormality affecting the constriction of arterioles, which help to control blood pressure. Other changes may contribute to increases in blood pressure, including accumulation of excessive amounts of sodium inside cells and decreased production of substances that dilate arterioles. Excessive amounts of cholesterol, fat, and calcium can form a buildup called a plaque. Blood flow through the artery decreases as the plaque enlarges. Blood cells can stick to this plaque and form clots, thus reducing or blocking blood flow. Hypertension is divided into 3 categories: prehypertension, primary hypertension, and secondary hypertension. While pre- and primary hypertension are considered idiopathic because their pathophysiology is not elucidated, secondary hypertension is associated with renal disorders, cardiovascular disease, endocrine disorders, neurogenic disorders, and lifestyle factors. Complications of renal disease reduces the flow of blood through the kidney due to atherosclerosis within a renal artery or due to a tumor-compressed blood vessel. In an effort to improve the flow of blood, angiotensin II is released. This stimulates the constriction of blood vessels while retaining sodium, chloride, and water until the blood volume increases. The increase in blood volume, along with the constriction of blood vessels, will increase the force exerted on the arterial walls by the blood. In addition, factors such as gene mutations or cellular dysfunction may also increase blood pressure. This is attributed to a decrease in mediators such as nitric oxide, which typically dilate the blood vessels. The pathophysiology surrounding endocrine disorders occurs within the adrenal glands and is associated with the overproduction of epinephrine and norepinephrine. Both hormones act to constrict the blood vessels, while cardiac output, the amount of blood pumped by the heart per minute, and TPR, the resistance of blood flow exerted by the blood vessels, increases. As a result, blood pressure is elevated. Furthermore, an excessive accumulation of insulin in the blood is also thought to be associated with hypertension. However, this mechanism is not only unclarified, but this general finding remains controversial. Lifestyle factors, including excessive sodium intake, excessive alcohol consumption, low potassium intake, lack of physical activity, smoking, stress, and obesity, are also associated with elevated blood pressure. The pathophysiological mechanism for each lifestyle factor is not well understood, and therefore is based on theories. For instance, cigarette smoking is thought to interfere with the action of nitrous oxide, preventing the dilation of blood vessels. Additionally, an accumulation of visceral fat synthesis is associated with an increase of angiotensinogen production, which stimulates angiotensin II secretion, resulting in constriction of the blood vessels, along with sodium, chloride, and water retention. Hypertension is typically asymptomatic until organ complications occur. In fact, headaches, nosebleeds, dizziness, and fatigue are often associated with hypertension. However, studies indicate that individuals with high blood pressure may experience these symptoms just as frequently as individuals with normal blood pressure. If hypertension remains uncontrolled and untreated, serious health consequences may arise. For instance, elevated blood pressure will cause damage to the blood vessels, such as developing weakened areas on the arterial walls. Such weakened areas are prone to rupture, which may lead to hemorrhagic strokes. In addition, these weakened areas may also prompt an accumulation of platelets to the damaged area site, which then stimulates blood clot formation. As previously stated, hypertension is divided into three categories: prehypertension, primary hypertension, and secondary hypertension. The etiology of each of these categories is associated with elevated systolic and diastolic blood pressure. Systolic blood pressure is the force of blood exerted on arterial walls during the contraction phase of the cardiac cycle, and diastolic blood pressure is the force of blood exerted on arterial walls during the relaxation phase of the cardiac phase. When determining blood pressure, systolic blood pressure is listed above diastolic blood pressure. For instance, on normal blood pressure is 120/80, with systolic blood pressure being 120 and diastolic blood pressure being 80. Moreover, a prehypertension blood pressure range is typically 120 to 139/80 to 89. A primary hypertension blood pressure range is typically 140 to 159/90 to 99. And a secondary hypertension blood pressure range is typically equal to or greater than 160 over equal to or greater than 100. Primary hypertension is 85% to 95% of all hypertensive cases and is often the result of environmental or genetic causes, even though these are not quite elucidated. In addition, obesity, diabetes, and heart disease may contribute to hypertension due to their genetic components. Current research focuses on clarifying the etiology of these genetic hypertension factors rather than environmental hypertension factors. Several studies suggest gene location on the DNA sequence affecting an individual's risk for hypertension. However, this finding has yet to be clarified. Secondary hypertension accounts for 5% to 15% of hypertensive cases and often has multiple etiologies. Renal causes, such as polycystic kidney disease, chronic kidney disease, and urinary tract obstruction, account for 2.5% to 6% of secondary hypertensive cases. Vascular conditions, such as narrowing of the aorta or vasculitis, account for up to 4% of cases. And hormonal imbalances account for 1 to 2% of cases and include steroid usage and oral contraceptive usage. In addition to these common risk factors, several other factors have been associated with secondary hypertension, such as brain tumors, regular alcohol consumption, nicotine usage, certain medications, hypercalcemia, and obstructive sleep apnea. Hypertension prevention and treatment is dependent on the category of hypertension and may include variables such as lifestyle changes and medication therapy. Each category of hypertension, including prehypertension, primary hypertension, and secondary hypertension, will include the lifestyle change variable, which focuses on weight loss, exercise, smoking cessation, and dietary pattern changes. Medications are often prescribed for individuals with a blood pressure of 160/100 or 140/90 for those with diabetes, kidney disorder, vital organ damage, or a risk for CAD. Prehypertension and primary hypertension consist of a one-drug medication therapy, such as thiazide-type diuretic, an angiotensin-converting enzyme inhibitor for blood vessel dilation, an angiotensin II receptor blocker for inhibiting its production, a beta blocker for increasing peripheral blood vessel dilation, or a calcium chain blocker for reducing blood vessel constriction by causing blood vessels to relax. Secondary hypertension often includes a two-drug combination therapy of these medications listed. The medical nutrition therapy treatment for hypertension should be prescribed based on the patient's weight history, level of physical activity, and intakes of sodium, alcohol, saturated fat, fruits, vegetables, and low-fat dairy products. In addition to evaluating the patient's food and nutrient intake, an evaluation of the patient's knowledge, beliefs, attitude, and behaviors are necessary for providing an appropriate diet for ensuring compliance. First, hypertensive patients weighing greater than 115% of their ideal body weight should follow a hypocaloric dietary pattern along with a consistent exercise plan. With each kilogram of body weight lost, a 1 millimeter of mercury reduction for both systolic and diastolic blood pressure can be expected. Sodium intakes should be reduced to no more than 1,500 to 2,000 milligrams per day. Such a reduction in sodium intakes found a 12 millimeter of mercury reduction in systolic blood pressure and a 6 millimeter of mercury reduction in diastolic blood pressure. Increasing fruit and vegetable consumption to 5 to 10 servings per day, increasing consumption of low-fat dairy products to 800 milligrams per day, and limiting alcohol consumption to no more than 2 drinks per day for men and 1 drink per day for women have also shown to aid in the reduction of both systolic and diastolic blood pressure. Lastly, adoption of the dietary approaches to stop hypertension, or the DASH diet, compared with the typical Western diet, has been evidenced to lower both systolic blood pressure by 5 millimeters of mercury and a diastolic blood pressure by 3 millimeters of mercury in patients with both prehypertension and primary and secondary hypertension. The DASH diet is rich in fruits, vegetables, low-fat dairy products, and nuts. It is low in sodium, total fat, and saturated fat, and provides adequate calories for weight loss or management. This case study's final diagnosis was a cerebrovascular accident with resulting dysphagia. Diagnostic criteria includes a CT scan of the brain, which showed a left frontal hemorrhage and a small right frontal hemorrhage. Treatments included therapy, such as speech therapy, physical therapy, and occupational therapy, a variety of medications, and nutritional support, including the placement of a percutaneous endoscopic gastrostomy. In the presence of a stroke, serum glucose levels, blood counts, electrolyte values, and prothrombin time values are often evaluated. As shown, the only laboratory values out of range upon the patient's emergency room visit was his glucose level along with his lactic acid and hemoglobin levels. Hyperglycemia is often evaluated because elevated glucose levels are able to accelerate the stroke process. Therefore, blood glucose levels will need to be stabilized within a normal range to prevent an acceleration of stroke complications. In addition, his elevated lactic acid value indicates that his body is under stress, while his low hemoglobin value indicates either poor iron intakes or poor iron absorption. As shown, his hemoglobin remained low during his admission at the nursing home and rehabilitation center. Along with low hemoglobin, his hematocrit was also low. These low values can be attributed to either poor iron intakes or poor absorption, both of which would be acceptable etiologies due to his declining oral intakes and his diverticulosis, which may prevent normal absorption of iron within the small intestine. Similarly, an inadequate intake of protein and energy may attribute to the patient's low albumin level, which is likely due to his declining oral intakes. Since the patient was admitted to the critical care unit, his electrolytes, notably sodium and chloride, could be low due to a consistent supply of intravenous fluids, which often causes electrolytes to decline. Furthermore, a blood urea nitrogen, or BUN, value is often evaluated to determine the current functionality of the kidneys. An elevated BUN often indicates a decline in kidney function. However, it is thought that a BUN may also rise during enhanced tissue breakdown, such as during brain tissue breakdown associated with a hemorrhage. Therefore, the bifrontal hemorrhages may be altering this patient's blood urea nitrogen levels. The patient's medication list is as follows. For his cerebrovascular accident, the patient was on a multivitamin, an antidepressant medication, a platelet aggregation inhibitor, and an enteral nutrition formula. For his diverticulosis, the patient was prescribed a medication called fruit butter. His hypertension was controlled by diet, and other medications include a medication for anemia, dementia, an anti-GERD medication, and an anti-epileptic medication. The nutrition care process. During the patient's hospital admission, he received a percutaneous endoscopic gastrostomy, which is a procedure allowing the placement of a feeding tube through the abdominal wall and into the stomach. The placement of this feeding tube was indicated due to the patient's dysphagic state, which inhibited him from meeting his daily nutritional needs through oral intake alone. As a result of the patient consuming less than 25% or less than 500 calories of a puree diet, he was started on a Gevity 1.5 tube feeding formula. The patient received the Gevity 1.5 twice daily as a bolus feed at 9 a.m. and 9 p.m. During his hospital admission, the patient received 1,185 calories and 50 grams of protein through his PEG tube and consumed at least 625 calories or less and 21 grams of protein or less from his puree diet. Upon discharge from the hospital 11 days later, the patient was transferred to a nursing home and rehabilitation center for speech, occupational, and physical therapy. In addition to therapy, the patient was to be monitored for diet progression. At the time of admission, the patient was prescribed a puree diet with no added salt. Due to his dysphagia and hypertension diagnosis, in which he consumed 25% to 50% at each meal. Since the patient was on a puree diet, he received a nutritional medication called fruit butter to supplement his increased fiber needs for diverticulosis and constipation management. Since the patient's oral intakes began to improve slightly, his Gevity 1.5 formula was decreased to 237 cc bolus feeds twice daily at 9 a.m. and 9 p.m. The patient received 711 calories and 30 grams of protein from his feeding. In addition, the patient consumed approximately 625 to 1,250 calories and 21 to 42 grams of protein from his pureed, no added salt diet. The case study patient was 5 feet, 5 inches in height and weighed 167 pounds. He had a BMI of 27.7, indicating an overweight status. According to the Academy of Nutrition and Dietetics Evidence Analysis Library, the estimated energy needs of older adults, those aged 65 years and older, should be calculated using 30 to 40 calories per kilogram of body weight per day in males. Therefore, this patient would require 2,277 calories along with 76 grams of protein, 25 grams of fiber, and 2,000 to 2,277 cc's of fluid per day. A usual intake diet history was performed to assess the patient's food and nutrition intake. This diet history method requires the patient to recall a typical pattern of daily food intake, which includes all meals, snacks, and beverages, along with a serving size approximation and the method of preparation. Since the patient's altered mental status inhibited his ability to fully comprehend this interview method, his fiancée was able to provide the needed details of his diet history. According to his fiancée, the patient consumes 3 meals each day, breakfast, lunch, and dinner. Breakfast typically consists of a chicken breakfast sandwich from a fast food restaurant, along with 8 ounces of an Original Boost supplement drink. Lunch consists of either a burger, barbecue chicken, or a lunch meat sandwich with either fries or chips and a Diet Mountain Dew beverage. Dinner typically consists of a meat, a starch, and a vegetable with sweet tea. The patient enjoyed snacking and frequently choosing high-calorie, nutritionally poor food items such as candy bars and related junk foods, as his fiancée stated. In addition, the patient consumes several Diet Mountain Dew beverages each day, typically in portions such as a 12-ounce bottle or 8 ounces poured from a 2-liter bottle, and also consumes unknown amounts of sweet tea and water throughout the day. Since the patient resides with his fiancée, she typically purchases and prepares most meals, and she uses a variety of cooking methods, including baking, broiling, roasting, steaming, grilling, and some frying. The only meal the patient's fiancé does not prepare is his breakfast meal, which he typically obtains from a fast food restaurant. The patient typically consumes an 8-ounce Boost supplement each morning. However, he does not supplement his diet with any other vitamin, mineral, or supplements. Past M&T instruction includes a high-fiber diet and a low-salt diet. The nutrition diagnosis for this case study patient is inadequate energy intake related to swallowing difficulty, as evidenced by dietary intake meeting less than 25% of estimated energy requirements and decreased nutritional laboratory values. Nutritional interventions for the patient consisted of placing a PEG tube for ensuring adequate nutritional intakes during periods of declining oral intakes, modifying the texture of his diet to prevent aspiration, limiting sodium intakes for controlling blood pressure, and supplementing fiber to prevent diverticulosis complications and constipation. The decision to feed a patient with a cerebrovascular accident should be made relatively soon after the occurrence to prevent malnutrition complications. Therefore, if a swallowing function indicates dysphagia and the gut is functional, enteral nutrition feedings are the preferred method of feeding. The Academy of Nutrition and Dietetics Evidence Analysis Library also supports the use of limited sodium intakes for decreasing blood pressure. Recent research found that reducing sodium to 1,500 milligrams to 2,000 milligrams per day decreases systolic blood pressure by 12 millimeters of mercury and decreases diastolic blood pressure by 6 millimeters of mercury. Also, the use of increasing fiber in the diet to promote soft, bulky stools for easy passage through the colon should also be considered. This requires less pressure and strain to move fecal material through the colon, which results in fewer diverticulosis complications. The overall expected outcome of these interventions was to maintain an adequate nutritional status while preventing unintentional weight loss and decreasing the risk for aspiration. In addition, goals were set to control the patient's blood pressure levels while preventing diverticulosis complications and constipation. Once the patient is able to tolerate a diet without the assistance of enteral nutrition, he will be able to incorporate fiber-rich foods, which are also low in sodium, into his daily diet to meet these goals. A Approximately 2 weeks after admission to the nursing home and rehabilitation center, the patient's oral intakes began to improve yet again. Since the patient was consuming 50 to 75% of his puree diet, or 1,250 to 1,875 calories and 42 to 63 grams of protein, his Gevity 1.5 bolus feeding was decreased from twice daily to once daily. Therefore, the patient received 237 cc's of Gevity 1.5 once daily, which provided 355 calories and 15 grams of protein. Continuous monitoring includes daily weights, daily oral intakes, speech therapy recommendations, and any available updated nutritional laboratory values. The patient was assessed within the first 48 hours of admission to the nursing home and rehabilitation center, and then was followed up on after 14 days of admission. In addition, the patient was followed and assessed each week during nutritional intervention program meetings, which included dietary, nursing, rehabilitation, and social services personnel. One of the goals, which was able to be monitored during the patient's stay, was ensuring an appropriate diet progression. During this time, the patient had increased his oral intake significantly, which allowed him to have his bolus feedings reduced from twice daily to once daily. The patient was consistently consuming 50% to 75% of each meal and even had several 100% oral intakes documented. Once the patient reaches a consistent 75% to 100% of oral intakes, he will be able to be taken off of the Gevity 1.5 bolus feedings. Along with monitoring the patient's daily oral intakes, weights, and speech therapy recommendations, the patient's tube feeding residuals were also monitored to ensure tolerance. At this particular facility, if a patient's residuals are greater than 100 cc's, the tube feeding must be held and restarted after 1 hour of holding. Fortunately, the patient had very low residuals during all of his feedings, indicating a good tolerance. Furthermore, while the patient's nutritional status was gradually improving, his altered mental status was progressing even slower. Therefore, all diet education, including modified diet texture and increased fiber and low-sodium diets, were completed with the patient's fiancé. The fiancé was highly receptive to such education and demonstrated understanding while asking appropriate questions. Since the patient was admitted to a nursing home and rehabilitation center, his stay will be somewhat extensive, typically until his therapy is completed. Therefore, the patient's fiancé was encouraged to contact the registered dietitian's office if she had any other questions or concerns. The registered dietitians will follow up with the patient during the remainder of his stay. However, upon discharge, it will be up to the patient and family to contact their office if any questions or concerns arise. Cerebrovascular accidents are often characteristic of many variables, including weakness, paralysis, incontinence, dysphagia, confusion, dizziness, headache, visual or hearing disturbances, and an inability to perform activities of daily living such as self-feeding. Since the ability to swallow is often compromised after a stroke, it is important to determine an appropriate feeding method for maintaining an adequate nutritional status in such patients, especially in an older adult population. Furthermore, since hypertension increases the risk for developing a cerebrovascular accident, those patients already at a stroke risk with uncontrolled hypertension should aim to control their blood pressure. Lastly, a tube-fed patient with a history of diverticulosis would benefit from meeting the minimum requirements for fiber intake to prevent constipation. This is beneficial since a lack of fiber intake may exert high pressure on the colonic walls and lead to diverticular complications such as inflammation and bleeding. Furthermore, If a CVA patient is found to have difficulty swallowing, a modified texture diet should be considered. Otherwise, enteral nutrition support should be the first line of nutritional treatment if the gut is functional without further contraindications. If other nutritional concerns are present, such as sodium and fiber intakes, supplementing a modified texture diet in accordance with an enteral nutrition bolus feed is acceptable for maintaining adequate nutritional intakes. However, if a diet progression is the goal, the method of nutritional support must also be altered as the oral intake progresses to prevent overfeeding. In addition, administering nutrition support as soon as possible after a cerebrovascular accident occurrence will assist in the prevention of unintentional weight loss in those greater than 65 years of age. As a result of maintaining adequate nutritional stores and ensuring weight maintenance, the elderly patient will significantly reduce their risk for both morbidity and mortality, which may have otherwise occurred.